Hello everyone, thanks for joining this course. I will be taking this course on the topic of ischemic stroke, and we'll be learning about ischemic stroke. A little introduction about myself. I'm a stroke fellow currently working with the University of Calgary stroke program. This is the part one of my stroke series. We're going to discuss about the epidemiology, pathophysiology, diagnosis of ischemic stroke and TIA, acute reperfusion therapies, and secondary prevention of ischemic stroke. So this is the part one, and I have made this part one specifically addressing the general background in ischemic stroke, the epidemiology, and we'll be going through the key studies around the background and the epidemiology in this section. About the background, ischemic stroke is defined as an infarction of brain, spinal cord, or retina and represents almost around 71% of all strokes globally. Advances in brain imaging have now currently shifted mostly the definition of ischemic stroke from a largely clinical determination to a tissue-based classification. In the past, as most of us would be aware, that a transient ischemic attack and ischemic stroke was classified based on the 24-hour criteria, where 24-hour was considered from the onset of stroke symptoms to a complete resolution as a transient ischemic attack. But now with latest technology and further MRI getting more computational power, we are able to describe tissue infarction on these imaging and scan technology. So mostly the definition has been shifted in that regard. Ischemic penumbra, coming to the definition in the 1970s, the pioneering experiments identified that much of the initial clinical deficits in patients with stroke were due to a hypoperfused, hibernating, electrically non-functional part of the brain, which was termed ischemic penumbra. This region progressively converts to irreversible injury over time, that is known as the ischemic core, but at a rate that varies considerably between individuals. However, with rapid reperfusion, this penumbral brain can be salvaged and can recover from normal function. So the core concept of saving this salvageable tissue out of the ischemic penumbra is the main principle for guiding all these acute reperfusional therapies and acute setting. So coming to the reperfusion therapies and the rationale, there was a landmark discovery formed the rationale of reperfusion therapies that have transformed outcomes of stroke patients with ischemic stroke since the first positive trial of stroke thrombolysis, which was published in a paper in 1995. Intravenous thrombolysis, which was intravenous thrombolysis, reduces disability when administered within the 4.5-hour stroke onset. Although selected patients with favorable brain perfusion imaging benefit up to 9 hours or after wake up, that is onset of stroke, uh, was observed as well. So IV thrombolysis, and the second limb of these reperfusion therapies is the endovascular thrombectomy option, which is also has a certain criteria and an indication which patients can go to have the endovascular thrombectomy or not, which I'm going to discuss later on. So coming to this New England Journal paper, which was MRI guided thrombolysis for stroke with unknown time of onset, or termed as the wake up trial, uh, they observed in patients with acute stroke with an unknown time of onset IV plays guided by a mismatch between diffusion weighted imaging and flare in the region of ischemia resulted in a significantly better functional outcome and numerically more intracranial hemorrhages than placebo at 90 days. So this trial actually used MRI as a diagnostic and a therapeutic modality both to guide people whether to go ahead with IV thrombolysis or not. We know from our knowledge of the MRI and that the diffusion weighted image becomes very sensitive within the first hour or two after the initial stroke onset, but the flare sequence is the one which takes time. So what is the flare and diffusion weighted imaging mismatch? So the mismatch is defined as when you're having the restricted diffusion on the DWI sequence, but you're not getting the flare sequence. Those patients who were randomized in this trial, they were randomized based on this flare mismatch with the diffusion weighted imaging. And the thesis or the rationale or the principle behind such a methodology was that possibly these patients are still in under the time window for having acute stroke IV thrombolysis, and the trial conclusions were very interesting. I'll just going to read through the trial conclusions, which were in patients with acute stroke with unknown time of onset. IV play is guided by a mismatch between DWI and flare in the region of ischemic stroke resulted in a significantly better functional outcome and numerically more intracranial hemorrhages than placebo at 90 days, which was also anticipated. With IV plays, you always have a risk of having an intracranial bleed. The percentage which we usually quote is around 5 to between 5 to 10%. It also depends upon other multiple risk factors. So if you see the results of this trial, there was an observation that out of 503 patients, uh, there were 254 who were randomly assigned to receive 80 plays and 249 who did not receive 80 plays. And the ones out of at 90 days, their primary outcome measure was an MRS improvement, which is the modified Rankin score, to assess whether there was a favorable outcome or not. So people who received the antiplays, there was 53.3% of the people who achieved a better outcome as opposed to 41.8% of the people who did not achieve the better outcome in the placebo group. So that was the difference which Wake Up trial came about with in 2018, and this was a very landmark paper. This is just the basic demographics of the patient baseline which were enrolled in this trial, and you can see the groups are very fairly well matched on age, on their gender, and the rest of the parameters, specifically the NIHSS score, the diffusion weighted imaging lesion volume, the time from symptoms recognition to the MRI, and the medium time of initiation of the thrombolysis, and the recognition of these symptoms and the comorbidities which were present in this population. So these are the results. I would bring your attention to the figure over here, which is a graph, and you can see there's a score on the modified Rankin score. You can well appreciate the atiplace group as opposed to the placebo group has a better functional outcome at 90 days. You see more lighter color areas which correspond to a lesser MRS score as opposed to the placebo group, which has slightly a darker color. So this correlates to a better functional outcome in those who received atiplace. Then there was an interesting other trial, which was the thrombolysis guided by the CT perfusion imaging trial after the onset of stroke. So their modality was their diagnostic modality was actually different in this study. It was called the Extend trial. The conclusion they came forth with was among patients in this trial who had an ischemic stroke and salvageable brain tissue, the use of it takes between 4.5 and 9 hours after stroke onset or at the time of patient waking up with stroke symptom resulted in a higher percentage of patients with no or minor neurological deficits than the use of placebo. There were more cases of symptomatic cerebral hemorrhage in the etiplase group than in the placebo group. And so I'll again going to read through these conclusions, which were very interesting. And among the patients in this trial who had an ischemic stroke and salvageable brain tissue, the use of it took place between 4.5 to 9 hours after stroke onset or at the time of patient waking up with stroke symptoms resulted in a higher percentage of patients with no or minor neurological deficits than the ones who had the placebo. There were more cases of symptomatic cerebral hemorrhage in the etiplase group than in the placebo group, which was also anticipated, but over here the benefits outweighed the risk. In the result section, there were 225 of the planned 310 patients that were enrolled in this trial, and it was terminated because of loss of equipoise after the publication of positive results from a previous trial. A total of 113 patients were randomly assigned to etiplase group and 112 to the placebo group. The primary outcome in 40 patients in the etiplase group and in the primary outcome occurred in 35% patients in the etiplase group and in 33% and in 29% patients in the placebo group. So this difference was also statistically significant, 35 as opposed to 29.5. So if you can see this as well, this is the same table 1 describes these study participants and different baseline variables, specifically age, sex, median, NIHSS score, clinical history of atrial fibrillation, geographic region where they were from, Australia, New Zealand, Finland, and Taiwan, time from stroke onset, and median time from stroke onset to hospital arrival, median time from stroke onset to initiation of IV therapy, median time from hospital arrival to initiation of intravenous therapy, imaging results. They were well matched, as you can see in table 1. And in the figure 1, if you see the score on the modified Rankin score, they are also more in the etiplase group, which are their lesser or lower modified Rankin scores in the etiplase group as opposed to the placebo group. And you can see lighter color area more in the etiplase group as opposed to the placebo group. And if you go to see the safety outcomes in the table 2, the major safety outcome, that was death within 90 days after intervention and the risk of symptomatic intracranial hemorrhage within 36 hours after intervention, which is present in the last 2 lines of this table 2, were that death occurred in almost 13 patients, which were 11.5 in the etiplase group, and 6.2%, which is 7 patients in the placebo group. And the adjusted so they did adjust this death and the hazard ratio in this population as well, but as I said, that the risk of hemorrhage and death opposed to a benefit was more in the benefit was more as opposed to the risk in this study. So then there was another study which was actually a meta-analysis, so which included these three very interesting trials: Extend, ECAS-4, and EPITHET. And they the meta-analysis title was Extending Thrombolysis to 4.5 to 9 hours and Wake-up Stroke Using Perfusion Imaging, a Systematic Review and Meta-Analysis of Individual Patient Data. Patients they concluded that the patients with ischemic stroke which occurred between 4.5 to 9 hours from stroke onset or wake-up stroke with salvageable brain tissue who were treated with etiplase achieved better functional outcomes than did patients given placebo. The rate of symptomatic bleed was higher in the etiplase group, but this increase did not negate the overall net benefit of thrombolysis. So this was a meta-analysis of all these three studies. Their interesting interpretation was that patients with ischemic stroke 4.5 hours to 9 hours from stroke onset had a better outcome in the thrombolysis group. This is the forest plot, and it is showing the three pooled studies within this table: Extend, ECAS, and EPITHET. You can see that in Extend there were 225 patients, in ECAS there were 116, and EPITHET there were around 69. And if you see on this forest plot, most of the variables which are tested against, the favorable outcomes are measured in favor of etiplase or an intervention rather the placebo. So they included age as one variable, less than 75, greater than 75. So favorable outcome between the two groups. Age, when they divided it into less than 80 or greater than 80, they still had better outcomes. NIHSS of less than 10 versus greater than 10. This was just one interesting result in this table where NIHSS of greater than 10 was coming in the midline of this forest plot. That was whether it benefits or not. It did not either highly favor the intervention, neither did it favor the placebo. Time strata, when they divided it 4.5 to 6 hours, 6 to 9 hours, the interventional arm was definitely having more benefit. Region, Australia, Asia, and Europe, whichever the study center was, did not have any bearing on the favorable outcomes in the etiplase group. Similarly, large vessel occlusion, whether it was large or small, it didn't depend either, so it also favored the etiplase group. So these were very interesting results which mostly favored the etiplase as an intervention of choice out of Extend, ECAS-4, and EPITHET. Then coming to endovascular thrombectomy, or EVT, that is mechanical clot retrieval via catheter angiography, it reduces disability in a broad group of patients with large vessel occlusions when performed within 6 hours of the time the patients with the stroke was last known to be healthy, and in patients selected using brain perfusion imaging up to 24 hours after stroke onset. So this was observed in Hermes collaboration pool analysis of these bigger trials: Mr. Clean, Escape, REVASCAT, Swift Prime, and Extend IA. So their conclusion was that endovascular thrombectomy is of benefit to most patients with acute ischemic stroke caused by occlusion of proximal anterior circulation. Irrespective of patient characteristics or geographical location, these findings will have global implications on structuring systems of care to provide timely treatment to patients with acute ischemic stroke due to large vessel occlusion. So Hermes collaboration pool was Very interesting in that regard, that it was kind of like going ahead and saying that you should go ahead if there's a proximal occlusion in the interior circulation, mainly the MCA, M1 and M2 divisions which are accessible. They should go after it if the other indications are met. So interpretation of their results were that endovascular therapy is of benefit to most patients with acute ischemic stroke caused by occlusion of proximal anterior circulation, irrespective of patient characteristics or geographical location. These findings will definitely have a global implication. Their findings in the individual data for almost 1,287 patients were taken into account, and 634 were assigned to the endovascular thrombectomy and 653 assigned to the control group. In the endovascular thrombectomy group, that led to significantly reduced disability at 90 days compared with controls, and the adjusted odds ratio was 2.49, which was very high for the endovascular group. The number needed to treat with endovascular thrombectomy to stroke disability by at least one level on MRS for one patient was 2.6, which is also very high. So subgroup analysis of this primary endpoint showed no heterogeneity of treatment effect across pre-specified subgroups for reducing the disability. You can see this is also forest plot, and you can appreciate all these patients which were pooled into this group. The interventional arm was favored when it was cross-tabbed and checked with the age. It did not depend on the age or the aspect score, which was second in line. They checked it with that as well. So the interventional arm was the one which was getting favorable outcome. The etiplase group was definitely the one who had the IV etiplase at the time, or the people who did not have the etiplase at that time. There wasn't any difference which was noted, and it also favored the thrombectomy arm. Stroke location, either the ICA M1 or M2, it also favored the thrombectomy. When the NIHSS was less than 10 or 11 to 15 or 16 to 20 or greater than 21, still the study population which received the etiplase, they did get benefit. And the ones who were randomly assigned less than 300 minute or greater than 300 minute, they were also having favorable outcomes in their Hermes pool. The interesting result out of this forest plot is in the aspect score group. So usually the conventional thinking over here is that people who have a better aspect score will be more suitable for getting into the thrombectomy arm. But even if you see in the study group with an aspect of 0 to 5, the interventional arm was getting was also suggestive of a favorable outcome. So that is something which is different from our understanding. And there's another ongoing trial going on, which is called the tension trial, which is for the results from that trial we're gonna tell us about what is best in people who have an aspect score which are lower than 6, whether to treat them with thrombectomy or not, would that benefit. This is the second interesting trial, the diffuse 3 trial. Their results were that endovascular thrombectomy for ischemic stroke up from 6 to 16 hours after a patient was last seen normal to be well, plus standard medical therapy, resulted in better functional outcomes than the standard therapy alone among patients with proximal MCA or ICA occlusions and a region of tissue that was ischemic but not yet infarcted. Their results were that they had around 182 patients that had undergone randomization, 92 of to the endovascular therapy group and 90 to the medical therapy group. And endovascular therapy plus the medical therapy as compared with medical therapy alone was associated with a favorable shift in the distribution of the functional outcome on the modified Rankin scale at 90 days. The odd ratio of this inference was 2.77, and a higher percentage of patients who were functionally independent, defined as a score on the modified Rankin scale of 0 to 2. 45% had a better outcome versus 17% who did not get the endovascular thrombectomy. The 90-day mortality rate was 14% in the endovascular therapy group and 26% in the medical therapy group. So both these values were statistically significant as well. So you can see a mismatch in their diagnostic modality which they employed over here. They found that volume of ischemic core, you can see in the figure over here that the figure describes a mismatch between the perfusion lesion and the ischemic core when they did the CD perfusion. So this was their sort of CD perfusion criteria, which they described that CD perfusion mismatch was sort of more indicative of going ahead with the therapy versus not going ahead. So CD perfusion mismatch became a diagnostic sort of like an important modality during an acute stroke setting, when to go ahead and when not to go ahead. So diffuse free trials, if you see on these forest plots as well, they have divided and they have checked different variables including time from stroke onset, which they have divided into less than 9 hours, 9 to 12 hours, greater than 12 hours. All these hour time windows are favoring the outcome. Volume of ischemic core, whether less than 10 mils, 10 to 25 mils, or greater than 25 mils, also supported the thrombectomy arm. And baseline NIHSS score of less than 13, 13 to 18, or greater than 18 also favored the intervention arm. Ages less than 70 or greater than 70 also favored the outcome, the favorable the endovascular therapy intervention. Aspect score of less than 8 or greater than 8 supported the favorable outcome. Site of occlusion, whether MC or ICA, also favored. Uh, then CT or MRI investigation at baseline with the mismatch favored the outcome. Determination of time of stroke onset to the time patient was last seen normal to be well, and the exact time of stroke symptom onset did not have any much difference. So people who woke up with a stroke versus those who had a particular time known, both favored the intervention. Gender did not have any difference. Race did not have any difference. Atrial fibrillation, slightly people who had an atrial fibrillation detected, they had a higher favorable outcome in the endovascular therapy group as opposed to those who did not. But still, both of these groups were highly getting favorable outcomes in both these groups. The patients who were eligible or whether they were not eligible for the Dawn trial both favored the endovascular therapy. So then this was the dawn trial. So in the diffuse trial, the time window was 6 to 16 hours. In the dawn trial, the reference was 6 to 24 hours. And their results were among patients with acute stroke who had last been seen to be normal well 6 to 24 hours earlier and who had a mismatch between clinical deficit and infarct outcomes for disability at 90 days were better with thrombectomy plus standard care than with standard care alone. So in their study, a total of 206 patients were enrolled. 107 were assigned to the thrombectomy group and 99 to the control group. At 31 months, enrollment in the trial was stopped because of the results of a pre-specified interim analysis. The mean score on the utility weighted modified Rankin scores at 90 days was 5.5 in the thrombectomy group as compared with 3.4 in the control group. Their their analysis suggested that at 90 days there was a better functional outcome with this increasing or extending the time window as well. So the results from their trial, as you can see, are also favoring the thrombectomy versus the standard therapy alone. And they compared these results with the mismatch criteria. Either the patients were randomized to group A, group B, or group C. All of them had a favorable outcome. Gender also did not had any bearing on the functional outcomes. Age either less than 80 or greater than 80 did not have much bearing. The baseline NIHSS score either 10 to 17 or greater than 17 favored thrombectomy. Occlusion site ICA or the M1 segment of the MCA both favored the thrombectomy arm. Type of stroke onset on awakening, witnessed stroke or unwitnessed stroke, all three favored the thrombectomy arm. Interval between time that patient was last seen normal and randomization whether it took place between 6 to 12 hours or 12 to 24 hours suggested also that the thrombectomy arm was better. Time from first observation of symptoms to randomization either 0 to 6 hours or greater than 6 hours also favored the study out thrombectomy group. So coming to the second portion of this part of this series, the epidemiology. The stroke, including ischemic stroke and hemorrhagic stroke, they affect around 3.7 million people globally per year, and it's the second leading cause of death with 5.5 million deaths per year. An estimated 1 in 4 adults will experience a stroke in their lifetime, and there are greater than 80 million survivors of stroke globally. The prevalence of ischemic stroke increased from 1990 to 2005 and then decreased from 2005 to 2013, ultimately leading to a slight, although not statistically significant, increase in the worldwide prevalence from 1990 to 2013. Global burden in those between 20 and 64 years of age, the prevalence of ischemic stroke has nearly doubled globally from 1990 to 2013, with an increase of 37.3% in associated disability adjusted life years. The incidence of ischemic stroke was higher in men, that was 133 cases per 100,000, than in women, 99 cases per 100,000 person years in the 2013 Global Burden Disease Study. The heritability, although some monogenic causes of ischemic stroke have been identified, such as cerebral autosomal dominant arteriopathy with subcortical infarcts, and leukoencephalopathy, which is called CADASIL, and cerebral autosomal recessive arteriopathy with subcortical infarcts and leukoencephalopathy called CADASIL. Most cases are sporadic. The estimated heritability of ischemic stroke is 37.9% when calculated using genome-wide complex trait analysis. So the global burden of disease study, that was the 2013 study, between 1990 and 2000, there were significant increase in the prevalent cases and total deaths due to hemorrhagic stroke and the ischemic stroke in younger adults who were aged between 20 and 64 years. Death and disability rates decline in both developed and developing countries, but a significant increase in the absolute number of stroke deaths among younger adults was detected in developing countries. So this was that was the study results from the global burden study in 2013. Their ischemic stroke group has an incidence of 2.14 in 1990 and a prevalence of 4.86 in 1990. And in 2013, this was observed in women to be 3.28 and in men to be 8.66. Similarly, the hemorrhagic stroke risk was found to be 0.86 in 1990 and 1.78 was the prevalence in 1990. In 2013, this was increased to 1.53 and 3.36 respectively. Similar differences were observed in the male gender, you can see in the table. Modifiable risk factors for ischemic stroke and interstroke study. So this was another interesting study which described these modifiable risk factors. These factors were a history of hypertension or a blood pressure of greater than 160 by 90 mmHg, low levels of regular physical activity, a high apolipoprotein B level to ApoA1 ratio, diet, a high waist to hip ratio, psychosocial stress and depression, smoking, cardiac causes such as AFib and previous MI, high alcohol consumption, and diabetes mellitus. Of these factors, self-reported hypertension or a blood pressure of greater than 160 by 90 mmHg carried the strongest risk, with an odds ratio of 3.14. And a population attributable risk of 45.2%. That is a very high risk. Other potential risk factors which this study identified were included sleep apnea, chronic inflammation, periodontal disease, and chronic kidney disease. In addition, some studies have demonstrated association with transient increase in stroke incidence and exposure when the population is exposed to air pollution. So this was the other genome-wide association study there, which concluded that there is a substantial heritability for ischemic stroke, but this varies for different stroke subtypes. Previous candidate gene association contribute little to this heritability, but genome-wide association study in related cardiovascular phenotypes and identifying robust associations. The heritability data and data from this study suggested detecting additional association will depend upon careful stroke subtypes. Their results were for all ischemic strokes, heritability was 37.9%. Heritability varied markedly by stroke subtype, being 40.3% for large vessel disease and 32.6% for cardioembolic, but lower for small vessel disease. No previously reported candidate gene was significant after rigorous correction for multiple testing. In contrast, 3 loci from related cardiovascular studies were significant, which was the PHACTR1 in large vessel disease, PITX2 in the cardioembolic stroke group and the ZFHX3 in the cardioembolic stroke group. So these three genes were associated with these three different subtypes of the stroke. So this is also a table show. I'm not going to go into the complete detail of the numbers and percentages of these genome-wide associations, but you can see this trend of this gene and the frequency and the number of strokes which that has been described. So there were multiple genes which were checked for an association in the three stroke subtypes: small vessel, large vessel, or the cardioembolic. This was the interstroke study, which suggested that 10 risk factors are associated with 90% of the risk of stroke. Targeted intervention that reduce blood pressure and smoking, promote physical activity, and a healthy diet could substantially reduce the burden of stroke. Um, in their findings, there were 3,000 cases, 2,337, that was 78%, had ischemic stroke, and 66663, that was 22%, had an intracerebral hemorrhagic stroke. And significant risk factors for all strokes were history of hypertension with the highest odds ratio of 2.64. Then current smoking, waist to hip ratio, and dietary risk factors, regular physical activity, diabetes mellitus, alcohol intake for more than 30 drinks per month or binge drinking, psychosocial issues, depression, cardiac causes, ratio of apolipoprotein B to A1, and were found to be other causes. So these risk factors were all significant for the ischemic stroke, whereas hypertension, smoking, and waist to hip ratio, diet, and alcohol intake were significant risk factors for intracerebral hemorrhagic stroke. This study has these tables are describing their results and describing these results in ischemic stroke and intracerebral hemorrhages. They have similarly made these five models, and in these five models they have further adjusted. With each model they are adjusting different variables and doing a regression analysis to find out the independent occurrence of a specific variable, which they found out with these odds ratios which are present in this table. This is the similar further results which they have elaborated in these four tables as well, which also suggested higher risk of ischemic stroke with high blood pressure having the highest association as opposed to other risk factors. So thank you very much for attending this part one of my talk, and we're gonna meet again for another academic discussion. I hope you would leave your feedback on this presentation. I would suggest you to read these papers and key studies which I have discussed in this presentation. That would further have a more clarification as opposed to understanding the further mechanisms and the specific therapies which we are at the moment providing in ischemic stroke. Thank you.